Welcome to the PH at Stanford Podcast. This new podcast series comes to you from the Vera Moulton Wall Center for Pulmonary Vascular Disease at Stanford, with the goal to eradicate pulmonary vascular disease by discovering fundamental causes, developing innovative therapies, disseminating crucial knowledge, and delivering transformative care. Today is the third in a three-part COVID-related series on ways to attack pulmonary vascular disease. Stanford PH specialists Vinicio de Jesus Perez, Edda Spiekerkoetter, and Andrew John Sweatt discuss the adult clinical approach and ways the Wall Center is fighting pulmonary hypertension across multiple fronts.
My name is Dr. Edda Spiekerkoetter. I'm an adult pulmonologist at Stanford, and I'm treating patients with pulmonary hypertension and also have my research lab.
Hi, I'm Dr. Andrew Sweatt. I'm also in the Division of Pulmonary and Critical Care at Stanford, treating adult patients with pulmonary hypertension and other general pulmonary conditions, and my clinical research focuses in pulmonary hypertension.
My name is Dr. Vinicio de Jesus Perez. Like my colleagues, I'm an adult pulmonary critical care specialist and physician scientist with expertise in pulmonary arterial hypertension and other pulmonary vascular disorders. Today, we're going to talk to you about what the Stanford Pulmonary Hypertension Program is doing to fight pulmonary hypertension across three fronts. Number one, the repurposing of drugs, discovery of biomarker through omics technologies, and the use of wearables for monitoring pulmonary hypertension patients. I will start first by telling you about our work with wearables. This is work that has been done in partnership with our friends at PH Aware, and it is a tool that will combine the use of the technology in the Apple Watch together with an application developed with our colleagues at PH Aware that will allow our patients to capture 6-minute walk data from the comfort of their living place, whether it's their home or their local park. Now, why is this important? Well, many of us have been affected by the COVID epidemic. As you all know, when you visit your physician, one of the key tests that the physician will offer is the 6-minute walk test. Why? It tells us how well your heart and lung are working together. It also tells us whether the medications and interventions that we are offering you are having the expected impact. The problem being that with COVID, it's become incredibly hard to host patients in our clinic. The 6-minute walk test is traditionally a test that has to be done in clinic, under the supervision of a respiratory therapist and with the proper assessment of the pulmonary hypertension specialists. For many of us, it's become very difficult to gauge how our patients are doing through video consultation in regards to the level of activity and how the medications are actually influencing that. To overcome that barrier, PH Aware and our group have partnered to test this new app, which is the PH Aware Walk Talk Track. This is actually an app that works with the Apple Watch, and it links wirelessly with your Apple phone. What the app does is it actually instructs you on how to capture a 6-minute walk test from the comfort of your home or any place locally where you can actually walk. It's simple. The app allows you to initiate the test, capture your symptoms, and then it tells you to walk for 6 minutes. It tells you when to rest. And once you're done, that information is uploaded to a cloud. That information comes to us using sophisticated algorithms that we have been developing. We can capture these numbers, your symptoms at rest, how much you walk, your heart rate, the changes in your heart rate. And this information is captured on a daily basis or as frequently as you can do. Now, why is that important? Because I'm not depending only on me seeing you every 3 months in order to know whether your functional capacity is improving or not, or maybe worsening. In an ideal situation where I have access to this technology, I can potentially identify a level of worsening that will prompt me to introduce a therapeutic intervention. For you, it means waiting less time in order to get the treatment that you require so that we can keep your quality of life and your level of function high, which is something that you will appreciate, your loved ones will appreciate, and for us, it will make our jobs much easier. This is currently being tested. We recently had 2 successful presentations at the American Thoracic Society that were featured as part of the program that I invite you all to check. We're currently conducting these studies. We hope to be able to put this out very soon. Once we publish and validate this will be available free to all users. And as I said, this is thanks to the support provided by PH Aware. And we're very proud to be part of this incredible project. I'm hoping that this is of great interest to you. Now I'm going to pass the baton, if you will, to my colleague, Dr. Spiekerkoetter, who will tell you about drug repurposing in pulmonary hypertension.
Thank you so much, Vinicio, for this introduction. I would like to switch gears a little bit and talk to you about what Stanford does to find better treatments for pulmonary hypertension. So to start with, I give you a little bit overview again. Pulmonary hypertension is characterized by narrowing of the lung vessels. This is due to cell growth in the vessels, which we also call neointima formation. Many of the current approved drugs that we have, they mainly dilate the pulmonary arteries, but they don't do anything to the cell growth in the vessels. The disease often progresses despite treatment, and patients at some point worsen, develop heart failure, and some even need to be transplanted. So what we are trying to do is find new drugs that could really reverse the cell growth in the lungs. A way that we have been using is to do something that's called either repurposing of drugs or repositioning of drugs. Repurposing of drugs means that you use drugs that are not approved yet for an indication, but that have been tested by companies and that failed for a certain disease, and you use these drugs for a different purpose. And one drug, for example, that we're actively working on is the drug ensifentrine, and I will tell a little bit more about this later. And then a second drug, which is repositioned, that's a drug that is already FDA approved. And we're using kind of off-targets effect of this drug or other side effects of the drug to see whether we can improve pulmonary hypertension with this drug. And the name of this drug is FK506 or tacrolimus. In pulmonary hypertension, many drugs have been repurposed over the years, and maybe probably the best drug that you know is sildenafil. Sildenafil, also called Viagra, was originally developed to treat angina, chest pain, because it was known that it relaxes smooth muscle cells. Then it was found as a side effect that men developed erections, and so that's when some smart people had the idea to say, well, let's use this as a good drug for erectile dysfunction. Then it was repurposed again for the use of pulmonary hypertension, knowing that, well, if this dilates vessels, relax vessels, it might even help pulmonary hypertension. And that's how we got the drug sildenafil, which many of you guys are using for pulmonary hypertension at a lower level than it was originally developed for. The advantages of drug repurposing is actually that it's much more cost effective than if you develop new drugs. It's much faster because new drug development takes often 12 to 15 years, whereas when you repurpose drugs, you can just skip many of the different steps in drug development because the toxicology is known, the dosing is known, side effects are known. So you can really start by using drugs and start with a phase 2 trial in patients. Because the side effects are known, it's often possible that you can use it as a lower dose. It has many advantages for the treatment for pulmonary hypertension. Downside is often that these drugs, when they are approved, they're often generic. Many pharmaceutical companies are hesitant or less interested in funding larger trials. That's where, for example, centers like the Wall Center or the National Institute of Health or other funding opportunities play a big role to really fund those clinical trials and really make these drugs available and test them in patients. Stanford has a big history of performing these what we call investigator-initiated clinical trials. We use certain drugs and we do very focused small trials with our patients. And I'm sure, when you're a patient at Stanford, you have been asked to participate in several of these trials. One trial we have performed with a drug FK506 or tacrolimus, which is an immunosuppressive drug that has been used over 30 years for patients after organ transplantation. And we're testing it, whether it really activates a certain pathway in pulmonary hypertension and whether it really reverses the growth in the lung vessels. And then a second trial where we are currently applying for funding at the NIH is with a drug called ensistarine, which is a cancer drug. And we're trying with a company to also use this to open up the vessels in the lung and help patients. In the past, it was often that people just look at side effects of these drugs and then felt, okay, if certain drugs have these and these side effects, maybe we can use the side effects for our disease as a beneficial effect. But more and more, we're also doing experimental screening, so high throughput screening of drugs, whether certain drugs activate a certain pathway. And this was actually how we found FK506 tacrolimus. More and more, we are also using computational approaches now to really predict whether certain drugs might affect certain pathways. And that's kind of where the bioinformatics, artificial intelligence, and all this comes in. So I would like to hand the baton over to my colleague, Dr. Andy Sweatt, who will talk a little bit more about this topic.
Thank you, Edda, for the introduction and the segue into what I'll be talking about, which is how we can use and how we've been using artificial intelligence and machine learning to help yield new insights and discoveries in pulmonary hypertension specifically. I think these terms, artificial intelligence and machine learning, are something that people are gaining increasing exposure to over time in the popular media and culture. It's commonly talked about on certain commercials. We know artificial intelligence has led to self-driving cars, and it's the reason that all the social media platforms are able to tailor advertisements specifically to our individual interest, in interest of trying to get more clicks, as well as facial recognition software that's embedded in smartphones. These are only a few common examples of artificial intelligence, which is essentially a field of computer science that aims to mimic human thought processes, learning capacity, and knowledge storage to provide useful tools. Machine learning is actually just a subset of the field within the larger umbrella of artificial intelligence. Machine learning is what I'll be talking mainly about today, which is the use of computational algorithms and statistical models to find hidden patterns in complex data sets that would otherwise be undiscovered, or to make predictions or identify patterns among variables within this complex data set. Before I talk more, I think it's important to understand that machine learning approaches can be broadly split into two main categories. Those that are supervised machine learning. These are methods in which you're trying to predict something, such as predict a certain outcome or classify or predict a certain feature, such as, is this a chicken or a duck, if given a picture? And the machine algorithm will spit out the prediction, this is a chicken, this is a duck. Whereas unsupervised machine learning is really designed to divide up a data set into new subsets within that data set, identifying novel subgroups of something. For example, in pulmonary hypertension, the use of all machine learning approaches is kind of recent on the stage. Our group has been one leader in this field, but there's other groups also increasingly applying these approaches to help us gain insight. Potential applications in pulmonary hypertension are very, very broad. When it comes to supervised approaches, this is when you have a data set, if you wanted to predict pulmonary hypertension outcomes like survival or something, and develop a tool that can predict how a patient is going to do over time. That's one way to do it. For example, you could use data from the wearables that Vinicio talked about before, the 6-minute walk distances over time. We may be able to identify an early signal with the computational algorithms and predict who's at risk for hospitalization or bad outcomes over time. These tools have been used to try to spur early detection of the disease. Pulmonary hypertension, the diagnosis really relies on an invasive procedure, as we know right now. So the idea is to use non-invasive data ranging from echometrics, imaging metrics, or even just claims-based data in diagnostic codes has been used. These have been applied to try to identify who's a pulmonary hypertension patient and who's not to help diagnosis. More specifically, my interests have been to use machine learning as a way to facilitate what we call deep phenotyping in disease. My initial interest in this field in general kind of spurred from my desire to combine my undergraduate biomedical engineering and computer science training with my subsequent clinical interest that I gained through medical school, residency, and fellowship, which was pulmonary hypertension. I think what I was struck by as I was exposed to my first pulmonary hypertension patients is that such a wide, diverse array of patients develops pulmonary hypertension. It can be due to genetic causes. It can be due to autoimmune diseases. It can be to certain drugs and toxins exposures, yet they all end up with the same disorder, pulmonary hypertension. Unfortunately, regardless of the cause, we are at the stage in pulmonary hypertension where we treat all the patients the same, kind of a one-size-fits-all approach. And this is the way we classify the patients based on the underlying cause. My initial thought is there must be a more elegant way, or there's probably another way to classify patients that would more relate to the underlying biology of the disease and potentially help us lead ourselves and pave a path towards targeting certain subgroups of patients with certain therapies who are more likely to respond to these specific therapies. At Stanford, we have a rich history long before I was here in making discoveries that relate to inflammation in pulmonary hypertension as it relates to the development of the disease process. My foundational work started with measuring a large number of inflammatory proteins and markers in the blood of pulmonary hypertensions, and then applying an unsupervised machine learning approach to really try to find patterns in this complex data where you're measuring a large number of proteins at the same time. The algorithm detected that there are these 4 subtypes of inflammation that exist. Lo and behold, when I looked at the clinical outcomes and characteristics over time, these patients had differences in disease severity and outcomes. Yet, these subgroups that I defined did not correlate with the clinical subtypes, such as idiopathic PAH, connective tissue disease PAH. Essentially, this tool is a way to reclassify patients according to this immune phenotyping approach. And now my work is going to be to take this further and look at what happens to immune phenotypes more over time during the disease stage. I'm going to analyze data from clinical trials secondarily to understand how these immune phenotypes respond to certain therapies to see if they have differential responses. On that side, I've been kind of applying unsupervised machine learning. And then more recently, I've been applying supervised approaches to identify patients who have adverse right heart effects of pulmonary hypertension over time, and as well as a study led by a clinical trial, NIH funded, led by my colleagues, Dr. Mark Nichols and Dr. Roham Zamanian, of rituximab, an immune modulating agent in PAH. Kind of a repurposed therapy that has been used for autoimmune diseases in general for years, similar to what Edda talked about. This was used for specifically patients with scleroderma-associated PAH. We measured a bunch of proteins in kind of exploratory fashion in the blood, inflammatory markers, and I defined a signature when measured at baseline before drug exposure predicts a more favorable response to the therapy. However, this was in one small cohort, and this signature is something that would need to be further validated and proven in subsequent groups of patients over time. We've heard already that PAH is a rare disease. It's time-consuming to run clinical trials because it's harder to find the patients to enroll than more common diseases like coronary artery disease or run-of-the-mill systemic hypertension. A lot of trials of novel therapies have failed in recent years, and the thought is that we need to be targeting certain subgroups of patients who are more likely to respond to these therapies to begin with, and machine learning may be able to help us achieve that fact. Before I finish, I'll close with the concept that sometimes there's this concept that machine learning and artificial intelligence technologies are something that are going to, the robots are going to take over the world mentality. And I think that when it comes to self-driving cars, these are machine learning and artificial intelligence algorithms that have been taken to the max level of sophistication. Whereas in the pulmonary hypertension and other medical fields, we're using the kind of under the hood algorithms, the simple algorithms that form the basis of that to help guide our research. And essentially, the important thing is that human oversight is very necessary in this process. People to understand what leads to the predictions that the algorithms make, or this. It's going to be important in our field as we apply these approaches to be very transparent in our approaches and try to present the data in a way that's interpretable for both clinicians and the PAH community at large. It's also important to be aware of this concept that has gotten a lot of attention recently called algorithmic bias, where essentially this is when machine learning models make inaccurate predictions and unfairly disadvantage certain subgroups of individuals due to inherent biases in the way the data you use to train these models is collected, labeled, and utilized. So for example, if you have disproportionate ethnicity breakdown in your data set, you're more likely to unfairly disadvantage certain subgroups. And so there's a whole field of science now focused on trying to avoid algorithmic bias. And I think the take-home point is that there has to be a large collaborative effort in our field in order to implement these technologies and approaches in our field while still being transparent and having a lot of human oversight in the process. There's a lot of exciting research happening at Stanford and with the Vera Moulton Wall Center for Pulmonary Vascular Disease. We've been able to keep our momentum up despite challenges presented by the COVID pandemic, and we're excited to accelerate research now that viral prevalence is slowing down. And as you can see, this kind of research that we are all doing would not be possible without all the patients generously volunteering their time and effort, and we hope that we can continue these efforts moving forward.
Thank you, Drs. de Jesus Perez, Spiekerkoetter, and Sweatt. And thank you for joining us here today on the PH at Stanford podcast. Join us next time. Until then, you can learn more about the Vera Moulton Wall Center for Pulmonary Vascular Disease at Stanford's vision to transform the way pulmonary vascular disease is understood and treated both locally and globally at www.stanfordph.org. And be sure to subscribe to the PH at Stanford podcast on iTunes or wherever you get your podcasts.